Hi, everybody. I am so excited on this happy Tuesday to have my brother from another mother, Dr. Evan Gwilliam, here to talk to us about coding. And truly, I don't know if there's anybody better to talk about this particular topic because he's kind of a junkie when it comes to this stuff. If you haven't seen Dr. Williams speaking at a state association event near you, where have you been? I happen to know that I book him all over this country, and if he hasn't visited your state, reach out to me afterward and we'll get him there. For those of you who might not be familiar with him, he did graduate from Palmer College Chiropractic, and it should come as no surprise, he was the valedictorian. He ran his own clinic for several years, and he is, like I said, a certification junkie. He has so many credentials behind his name, it won't be long. We'll be wrapping them around the back of his business card. Certified professional coding instructor, medical compliance specialist, certified professional medical auditor. Now that I'm going through that one right now, let me just say he really is a genius because this class has given me, well, we won't talk about that. Anyway, he provides witness testimony, medical record audits, does consulting, online courses for healthcare providers. He has also helped to with the ChiroCode desk book, which is a must-have. I hope you all have it. Writes books, articles for trade journals. He is a sought-after seminar speaker. He is working for PDC. What is your official title with them now? Because I can't ever.
Clinical director.
Clinical director. He also has his bachelor's degree in accounting, master's in business administration. Did I mention he's a genius? And he's just a lot of fun to talk to. So anyway, I'm going to be quiet now and turn it all over to Dr. G.
Excellent. You know what? It's easier to boast when someone else is doing it for you, right? So that is terrific. It is exciting to be here with you guys. I am always honored to be a part of this. Let's see here. Let me go back to my first slide real quick. Sorry, jumped in the middle. There we go. All that she said about me is true. Christy and I go way back, and I love this topic. I like talking to chiropractors about what they need to do when they're trying to get their billing done, when they're trying to figure out how to document properly, because nobody told me when I graduated 16 or 17 years ago now. And I wish I knew this information. So that's kind of what I'm trying to get out there. And I know that there are a lot of issues with payers and, and state boards and groups, reviewing things. And it's hard. It's hard doing business these days sometimes. There's a lot you got to worry about. So my goal with you during the time we have together today is to make your life a little easier. I want to share with you some stuff that I think should simplify things and make it so that you can find the answers you need, get your work done, take care of your patients, create great records, correct billing, and just move on with your life and get paid properly and not have to sweat over it afterwards, So that's what I'm trying to do for you today. As Christy mentioned, I'm the clinical director for EHR software for PDC. So my job is to make sure that our software does what the clinicians need it to do, mostly so they can stand up to third-party scrutiny and make sure their bills are correct. Prior to that, when I was at ChiroCode, I helped write the ChiroCode desk book for many years. And a lot of this information that I've got in these slides is really what I helped create or add to ChiroCode in the past. And I'll show you some information about ChiroCode if those of you are looking for more reference material when we're done here. If you just can't get enough and you need more help, I'll give you some pointers and places to go. You do see here my contact information. So here's my deal. If there's something in this presentation that you are confused about, want some clarification on, or even something you want to ask me that's not in the presentation, I'll take an email from you and I'll answer a quick question. But if you want to, ask for my help for hours and hours on end, I'm going to start charging you for that. So, but I'm happy to answer a quick question. So feel free to use my contact info. And if you want to know more about our software, always, email me and I can tell you about that. So today I'm talking to you about codes that chiropractors confuse sometimes. I think these are CPT codes or procedure codes that are very commonly billed by chiropractors, but we don't always know what they are. I think a lot of us use them interchangeably or heard something from someone once that makes us think we know what's going on and we don't. And so I'm going to make it my goal with you today to make sure you know what these codes really are for, when to use them and when not to, okay? So as Christy mentioned, this is me. That's just a list of all my certifications. Everything she said about me is true. I really am that great. Okay, so we'll just move on from there. But I would love to come and speak in your state. I'm looking at next year right now. I'm looking at my calendar, and ChiroHealthUSA is very frequently my sponsor. And they love to send me out to places, and we love to come out and teach and help you guys. So here's what we're going to take away from today's presentation. All right, we're looking at these 3 CPT codes, 97110, 97112, and 97530. And the first thing we're going to do is we're going to look at some of the fundamentals. I'm going to talk about some general concepts around this group of codes and where they relate to the other codes in the code set and what these services are all about. And then we'll talk about the details for each code, what its description is, what the rules are around it, and where the rules come from. And then we'll talk about when to use modifiers. We'll even look at what diagnoses make sense for these particular codes. Which diagnoses can I use to justify 97112 that I can't use for 97110 and that type of thing. So I'll make sure that we cover that. And I really, really want you to be able to nail the documentation requirements. Documentation is kind of my passion. There's sports chiropractors, there's pediatric chiropractors, and I respect them greatly, but my thing is documentation. And so I want to make sure that you create records that very clearly support these codes, and you can be confident that they're accurate and precise and nail it. So we're going to go through some of that. I also want to make sure that you don't get denials. I want you to again, be confident that when someone else asks for the records to match the claim that you sent to them, they go, yeah, those look good. They match everything. All the essential elements of medical necessity are present. And there's nothing they can do to make your life more miserable, because they have to accept that you do a great job with your records and your billing on top of your clinical skills, right? So we want the best of all those worlds. So a couple things. This is my reference material. I need you to know where this stuff comes from. I'm not making this up. Well, I guess if I'm saying it comes from the ChiroCodesk book, and I helped write the ChiroCodesk book, I guess I am making it up to some extent. In fact, here, let me just show you mine real fast. It's right here. Right, so here you go. There's my ChiroCodesk book. The 2019, the 20 is coming out pretty soon. I believe it'll be available, I think probably beginning of October when the codes are updated. So if you don't have a ChiroCodesk book, it's a great reference. Your alternative is the American Medical Association CPT book, or Current Procedural Terminology. And that's where we get, here's mine. There we go. We'll just go through my shelves here. So here's my CPT book, right? It's a big fat book. This is the Optum version of it, which is even bigger than the standard one. You get right from the AMA. I've read all these cover to cover, lots of fun. I gather my kids around sometimes at night and we read stories from the CPT book, right? We're going to reference some CPT assistant articles, which are newsletters that come from the American Medical Association to clarify some of the codes. But I'm going to borrow a lot of what I have in this presentation from Medicare. And I just chose one of Medicare's guidelines on physical therapy codes from CAHABA, which is a Medicare contractor that serves areas in the Southeast. I think it's Georgia, Tennessee, Alabama, I think are the ones that have CAHABA. So if you don't, in those states, that's fine. But these Medicare guidelines are so standard, it's the gold standard. So they're fairly universal. So we're going to use those. And I think we're pretty safe if we say, hey, to have this code in place, you got to have this and that. Pretty much every other payer, Blue Cross, United Healthcare, Aetna, they're all going to be, yeah, okay, if Medicare says it, fine. With some exceptions, but for the most part, Medicare is the gold standard, so we'll use that, even though Medicare doesn't pay for these codes we're looking at. They do pay other providers, and they have rules and the other, so it should work. Find a Code is an online resource. I'll show you a screenshot of it in a second, but it's a great way to look up some of this information at your fingertips. And it's a service I subscribe to. You can check it out. I'll show you kind of a little more. And I pulled some private payer policies from Anthem Blue Cross because I tweaked this presentation once for providers in that area. So if you don't deal with Anthem, that's fine. But again, some of their policies are going to help us understand what was probably accepted by other payers as well. All right. So that's kind of where we're going. This is what the CPT book typically looks like. On the left and on the right, you got your CPT assistant. The CPT assistant is a newsletter that the American Medical Association puts out. I think it costs $300 or $400 a year to subscribe. And once a month, you get this newsletter that's 30 or 40 pages long. And it talks about they had meetings in the past month and they came up with these clarifications for various codes, and specialty societies asked them questions and they responded. 98% of the time, the stuff in this has nothing to do with chiropractors. There's nothing in the CPT assistant that matters to chiros. But every once in a while, really once every year or two, there's something in there that is important for you to know. And so I'll show you a few of those things as they pertain to the codes we're discussing today. If you want more reference material, and you don't want to just buy all these books, you want to get it online, I would highly recommend this online search tool called Find a Code. And this is just a screenshot. It's a subscription-based service. It starts at $5 or $6 a month, I think, and then it goes way up from there. But you can get all kinds of coding information right from there. So check out findacode.com. I think you can sign up for a trial and mess around with it. I really like it. It's a company that's associated with ChiroCode, but I don't have any, how do you say? I don't have any stake in it or anything. I'm just telling you this is a tool I use, and you might want to use it too. So showing you my references now, let's move on and let's get into the meat and potatoes here. So therapeutic procedure coding for chiropractic. We're really looking at therapeutic procedure codes, and there's quite a few. These are the top 7 used by chiropractors in order of popularity. So according to my research, which I was just going to double check, but I didn't get a chance before this presentation. Last time I actually updated this was a few years back, but the most commonly used therapeutic procedure code by chiropractors is 97140, which I'm not talking about today. That one's a whole other discussion, and we maybe can field questions if we have time. We can talk about 97140. I wanted to contrast number 2 on that list with number 4 and 5. 97110, which is therapeutic exercises, 97112, which is neuromuscular re-education, and 97530, which is therapeutic activities. The reason I want to talk about these 3 is because they have some things in common and some things that they don't share in common. And one of the issues I run into when I'm working with my clients, doctors who are getting into trouble because they're getting audited or their state board is coming after them or they're being accused of billing irregularities, is, well, I was billing 97112 and they told me I couldn't get paid for it. So I just started billing 97110 and it seems okay. And what you need to understand is the codes are not interchangeable. You can't just swap one out for the other. You got to know what the codes are. They wouldn't create 2 codes that meant the same thing. There's no reason to do so. So these codes are for different distinctive services, and you need to make sure that your records reflect what these codes have as requirements. Okay. So again, there's other codes on this list, and just to let you know, this list is by popularity. So among the 971 to 975 codes, which are the ones in the therapeutic procedure category, which I could show you in my book there, the most commonly used codes by chiropractors are at the top of this list, and the least common are at the bottom. Okay. What we should do another time is have a discussion about some of these at the bottom of this list, the 97150, 97139. There's a lot of interesting things we could discuss about those codes, but we're not going to today because I'm focusing on those other 3, 110, 112, and 530. All right. So that's where we're headed. I'm going to give you some background information about these codes in general, and then again, we'll get into the specifics. So if I were to go through my CPT book here and read the introduction to the section of the therapeutic procedure codes, it tells us that the definition of these codes are, they are a manner of effecting change through the application of clinical skills and or services that attempt to improve function. Now, I underline the word function, and I watch for that word throughout this presentation. It appears a lot. The bottom line is this: therapeutic procedure codes are for when you have a patient who has a loss of function and the service improves their function. So your goal in establishing necessity for these services is to show that there was loss of function and that your service improves the function. It's all about function, okay? It's a buzzword. Watch for it here in the slides. We should have done like some bonus, like you win a candy bar, if you can count how many times I have the word function listed in this presentation during the next 45 minutes or so. So the other key phrase in that paragraph is clinical skills. So these codes require clinical skill. And what that means in some instances is a provider with a license, even a physician, must be the one to provide these services. Or you must demonstrate that whoever is administering them has some sort of clinical skill or training. And we'll discuss that concept a little bit more in a minute. The second little paragraph or phrase here is from Medicare, not from the American Medical Association or the CPT book, but from Medicare. And they say that therapeutic procedures attempt to reduce impairments and restore function through the application of clinical skills and or services. So it's kind of the same words, just moved around a little bit. Essentially, you have to improve function and show that it required the skill of a clinician or someone with a particular skill set to administer and deliver that. Now, this is borrowed from a private payer policy, Anthem, which is one of the Blue Cross plans. And this is what they say. And I apologize for reading this to you, but I'm going to anyway. Rehabilitative services are intended to improve, adapt, or restore functions which have been impaired or permanently lost as a result of illness, injury, loss of a body part, or congenital anomaly involving goals an individual can reach in a reasonable period of time. So again, there's function, and then there's just talk about goals. We're going to talk about goals later too, appropriate goals for each of these services, because they may not have the same goals. Reducing pain, improving range of motion, improving function, those are kind of too generic. We need more specific goals for these services. And then Anthem says, look, we will not pay for these services. Benefits will end when treatment is no longer medically necessary and the individual stops progressing towards goals. So another good buzzword in here to talk about is progress. In order to substantiate these services, you really got to show progress. You got to show that the service shows the patient had some problem and it's moving forward towards a destination. You can't just keep having to do exercises because exercise is good. You have to have progress, measurable progress, preferably quantifiable measurable progress, meaning there's a number that you're measuring something and that number is improving somehow. Okay, and we'll talk about some ways to do that. So that's from private payer. So in general, for any of these codes, again, I'm going to get into the specifics, but in general, for any of these codes, here's what I'd like to see in the first visit. So I'm looking at your first visit records. I'm opening up, I'm reading through them. I want to know why you chose to do therapeutic exercises later on. There has to be history and objective findings which support the correlating diagnoses. So if you diagnose the patient with a strain of muscles, right? A strain of some muscle somewhere in, like say in the neck, and your history says the patient just woke up and had no problems and suddenly they were there, that history doesn't really correlate. But if you say, hey, they were in a car accident and now I'm saying strain of muscles in the neck, okay, I can see the history tying into the diagnosis, right? It makes sense because there's trauma. If the objective findings say, I didn't even examine the neck, but I believe they have a strain there, that's no good. You need some objective findings. So you palpate it, you do some range of motion, you do some orthopedic tests, and those things all support the existence of that strain. Those things need to be in place to support diagnosis that ties appropriately to these services. All right. And I think it makes sense to do therapeutic exercises to treat a strain because you need to repair those damaged tissues. All right. But if your diagnosis is pain in the neck, all you do is cervicalgia, I'm not sure that you can very clearly justify doing therapeutic exercises to treat pain for pain management. You could make an argument there, and I believe that there's research out there that talks about how exercise helps with pain. But what I'm saying is you're better off if you can have a great diagnosis that's actually a condition and not just a restatement of a symptom, because pain is a symptom, a strain is a condition, and you're much better off providing the payer with evidence of a diagnosed condition that needs to be repaired as opposed to a patient complaint that's subjective. The other thing I want to see in the first visit is functional limitations. There's that word function again. I want to see functional limitations or deficits. I want you to say the patient can't sleep through the night. The patient can't lift up a bag of their laundry in the basket. Functional limitations. And you can document that through a lot of different ways. If what you're saying is the functional limitation is related to motion, you can specify the degrees, right? If the functional limitation is related to their strength, you can talk about grades, strength grades, and say this, it's lower or higher. If you're saying they have loss of balance, then you can discuss, well, they need to have a walker, or they need a cane or something. If it's a loss of coordination, then you talk about what specific deficits of coordination they're experiencing, dexterity or whatever. They're unable to pick things up because of the numbness in their arm, something like that. Loss of mobility, you can talk about distance. I didn't put it in the slide, but distance, well, they can only get about 10 yards and then it's not working anymore. So all of those are great ways to document functional limitations that can help justify the need for these services later on. In the first visit, that's where I want to see the plan come together. As an auditor, as Christy mentioned, I'm a certified professional medical auditor. I look at records all the time. And I really, really want to see a clear plan in that first visit. I think most chiros are doing that now. I cannot overemphasize how important it is to come up with a plan. And in the plan, you say, hey, here's what we're going to do. So describe the service that you're going to provide and their purpose. This is where you can say, we're going to do this because here's how it's going to affect the loss of function. If the loss of function was strength related, and you say we're going to do this machine that's going to help improve their strength and measure how, we get those neck muscles strong again, that's great. That's very clear to a reader. Of course, during the plan, you say what area you're going to treat. So you might mention the neck. I've seen records where they're so generic and so copied and pasted that they never even specify what they're going to treat. They just say, we're going to do exercises on this patient. And you don't even say anything more about it. That's worthless. You might as well not document it at all. I want to know where you're going to treat it. I mean, it's simple. The patient has a problem in their neck. We're going to treat the neck. It's easy. But you'd be surprised how often those kinds of simple things are left out. And then this is where you say the frequency and duration of those services. So, 3 times a week for 3 weeks or whatever. And the goals with the outcome you expect. So if it was loss of strength, the goal would be improved strength. And how are you going to measure that? Well, we graded the strength and it's a 2 and we expect to take it to a 5, over 8 weeks or whatever it is. So a measurable outcome, a goal tied to that service. That's all just the first visit, okay? During the typical treatment visits that follow that first visit, I want to see relevant subjective and or objective changes. I don't care so much about a restatement of their subjective, they were hit by from behind, went at a stoplight, and their neck began to hurt. You told me that already back at the first visit. What I want to know is, how has that changed? So if you see them 10 times after that, I want to know during those 10 times, what changes every time? The key in great record keeping is creating a really great solid first visit with a nice solid plan, and then telling the story with the subsequent visits that describes the changes from the beginning to the end. And there is an end. Same thing with the objective findings, Well, originally the muscle strength was X, and now it seems to be a little bit better. It's Y, but over here it's not. It's still getting worse or whatever. Changes is what the daily notes should capture, not just a restatement of what was in the first note, okay? Time. These are all time-based codes, and I'm not going to go into the issues around time, but the short of it is they're 15-minute codes, and you can document 8 minutes to bill it once or 23 minutes to bill it twice. There's more to that story, but that's not what I'm here to talk about today. I got too many other things to tell you. And if you want to ask questions about it, we can address it at the end if there's time. Pun intended. So let's say it's visit 5, and you said, hey, we were going to do these exercises where I was going to hook the patient up to this rubber band. We're going to put this harness on their head, and we're going to do this to re-strengthen those rotator muscles. But today they were hurting so bad we had to modify it somewhat, or we increased the resistance or decreased it, whatever. At daily visits, you can talk about how you change the plan, but if you don't have to change the plan and you're following it exactly, you can just say, hey, we did it according to the plan. And if an auditor wants to see the plan, then go back and read about it when you wrote it out the first time in the first visit. You don't have to restate the plan every visit. I think that's redundant. You could, but I think that's just filling up extra space, and you can just say, there was a plan on this date, go see it over there if you want. I don't need to see it repeated. And then at daily visits, you can say how the patient responded. Say, they didn't have any residual pain afterwards, or it was a little achy or whatever, and I told them to ice it, that kind of stuff. And then periodically, you're going to do reassessments, right? You're reassessing the benefits of these exercises. So at those reassessments, a re-exam, which I recommend you do every 4 weeks at a minimum, and during the first 4-week trial period of care, you do them at 2 weeks, which is following clinical compass guidelines, of which I used to be a board member. And anyway, so I believe that reassessment should be done at a minimum of every 4 weeks, preferably at 2 weeks during the first 4-week period, and then every 4 weeks thereafter. And this is where you would look at the functional progress. You'd say, the patient said that when they carried their laundry basket around, their neck was killing them. So it turns out that they can get all the way through the first load of laundry without pain. By the second load, it's killing them. And I told them to, kick their kids out of the house so they have less laundry to do. And that's how we're going to solve it, right? And I say that because I have a bunch of kids and I do a lot of laundry sometimes. At the reassessment, it's very critical that you take a moment to mention the goals. You say, hey, I did this exercise for the purpose of improving strength or improving range of motion or whatever it was. And at the reassessment, you say, I had that goal and we met it. We didn't meet it. And you explain why. We met it because I'm a brilliant doctor and I figured out what to do. We didn't meet it because I'm a lousy doctor, or because the patient re-injured themselves or didn't follow my recommendations, or whatever the reason is. Take a moment at the reevaluation to mention that, and just take one sentence and say, hey, we had a goal. Here's what's going on with the goal. Because I see far too many records where the goals are just never referenced again, or they're not focused on enough. And the goals are a critical way for you to establish medical necessity to make sure you get paid for these services. All right. If appropriate, you can suggest alternative treatment. You can say, look, I did this exercise, it's not working, and we're going to keep going. We're going to do another exercise instead and see if that one helps. And if it doesn't, we're going to stop, send them over to somebody else, maybe, try a different type of treatment. Okay. So that's general documentation at the initial visit, the typical treatment visits, and the reassessment. We'll go through some specifics here. I'm almost there. A few more generalities to cover with you first. When you look up the therapeutic procedure codes in the CPT book here, we are told that the codes are not limited to a particular specialty group. So some people look at that and go, well, we can't bill those because those are for physical therapists. And that is not true. The CPT book, anybody can use any code as long as your state scope allows it. Delegation to clinical staff for these particular services we're going to discuss is governed by state licensure, and it's often a source of contention with payers. I'm going to say the general trend now is they cannot be delegated. Pretty much these codes I'm talking about now need to be done by the clinician. There may be exceptions, and some of you may say, wait a minute, I know that my state allows me to have the exercises supervised by my staff member who doesn't have a license of any sort. As long as I've trained them and I can document I have, great, you're fine. I'm just letting you know that more and more payers and even state boards are pulling back from this and saying that certain services require so much clinical skill that they don't want you to delegate them. And I've seen doctors lose money because they were delegating, and the payer came back and said, nope, we only pay for it when the doctor does that service themselves. So be aware of that. Check with your payer contracts, check with your state board to make sure you know how it works in your area. And again, with time-based codes, these are the ones we're discussing today are all 15-minute increments. You may have heard of the 8-minute rule, which again, I'm not going to elaborate on today, but if you do a bunch of services and they're all 8 minutes, you're below average. They're expecting the average to be 15. 8 is the minimum threshold. And if you want to build 2 of these codes or one of these codes, 2 units, you need to hit at least 23 minutes. You can't do 8 minutes of one code and 8 minutes of another. You have to do 23 minutes total before you can build both of the codes. And if that was too fast of an explanation, email me and I can explain or send you to an article I wrote up on it for ChiroCode a while back. A couple other things you need to know. These codes require a physician or other qualified healthcare professional, QHP, to have direct one-on-one contact for all of these. You can't be in the other room while the patient's doing these things. Someone has to be there. It has to require the presence of someone to monitor them and make sure they're doing it right. That's how you prove there was clinical skill required, right? So that's what the second bullet says. You got to have clinical skill. And if you have a patient in there who, like, let's say I had a patient and I said, hey, I want you to do these neck glide exercises, right? And I want you to bring your chin forward and try to keep it level, keep your ears level, and bring it back. And you know, the first time you teach them those exercises, you watch them, you guide them, you make sure they're doing it correctly, and pretty soon they can do it on their own. And the next time they come back to see you, if you say, hey, go back in the back room, do those chin glide exercises I taught you, that is not a billable service. You have to require and even if I say, hey, I'll stand here and watch you do them, you need to be able to say, oh, you know, you got to tweak this, or let's give you a new exercise. You need to prove that it needs the presence of someone who's got skills. You can't just send people away or even have people stand around watching patients do things that they can do without supervision, okay? Or if you have a bench press, equipment in your office, or again, better exercise, like an exercise bike, and it doesn't take any clinical skill for them to sit on that bike and push the pedals around, and it's not even related to the neck, really hard to justify that as a therapeutic exercise, okay? So a few more things. If you want to sit around and explain to the patient the difference between slow twitch and fast twitch muscle fibers and Golgi tendon apparatus and stuff like that, and explain the benefits of these exercises, that's terrific, but there's no separate coverage for educating patients, okay? You can't get credit for time for education. You have to also believe that they're going to have some changes within a reasonable and generally predictable period of time. So if you see a patient who you know is going to take years to get that range of motion back because of the nature of their degeneration or injuries, payers are going to have a hard time with that. All right. It has to be a reasonable and generally predictable period of time. Also, just so you know, for these codes, Medicare secondary payers often require the GP modifier, which means there's a physical therapy plan of care in place. If you want the patient to be responsible for these services, or if there's a secondary payer who will pick up things that Medicare doesn't, you have to attach the GP modifier to these codes. I learned recently that United Healthcare, I believe as of July 1st this year, is requiring the GP modifier in all these codes if they're the primary. So double check that, but I believe if you're billing United Healthcare, they're saying you have to add the GP modifier to the codes we're talking about here, all the therapy codes. So check into that and verify, but that's what I had been told they had released something in April that said that they were going to make that permanent as of July 1st, borrowing that modifier from Medicare. All right, so now finally, I'm to the specific codes. We're about halfway through actually our time here, and this is about where I wanted to be. So the first code, this is one of the most commonly billed codes by chiropractors, right? 97110. 97110, its definition in the CPT book is therapeutic exercises to develop strength and endurance, range of motion, and flexibility each 15 minutes. And here's the thing about this code. I like it. I like it a lot because it covers anything where the patient's lost strength, endurance, range of motion, and flexibility. And I tell you what, a lot of patients that see chiropractors have lost strength, endurance, range of motion, and flexibility. And that's why they're there. So this service is applicable to a lot of stuff that we do. The relative value unit, I should have updated this. It's 0.03 higher than that. It's 0.87. RVUs is a Medicare value system where they talk about how codes, the value of different services relative to each other. And they multiply that times Medicare's dollar amount they're given by Congress every year for like the budget. So that can kind of tell you where these are reimbursed at. So you know what, just look at 0.84. Remember that, because when I get to the next code, you'll see how it differs in value to this one, okay? So if you want to know more about RVUs, again, email me and I can see. There's lots more we could talk about. For those of you who, let's see, I'm trying to think where I'm speaking next. Wisconsin, I'm speaking in a bunch of places, but when I speak in Wisconsin next month, I was given 8 hours to lecture, and it's 2 4-hour sessions, and I'm really excited about it, because I don't have to skip over stuff like this. I can dive into RVUs and explain it to you for 15 minutes, and we can all be on the same page, and I can impart everything I've read and learned to you guys. So again, bring me out to your state association, and I'll have a lot more time to cover some of this fun, deep stuff. And I know some of you woke up this morning and said, gosh, I really hope that he's going to explain RVUs in detail, but we're just not going to get to it, so I'm sorry to disappoint. This code is great when the patient has loss of joint motion, loss of strength, loss of some sort of function, some functional capacity. And there are examples here like treadmill, isokinetic exercises, stabilization exercises. If you are stretching the patient, if you are strengthening the patient, those are great things to bill with this code. And if the patient just can do the exercise on their own later, it's just not covered, as we mentioned previously. So what else do we need to know about this code? Well, this code is not interchangeable with 97112, which is the next one I'll talk about. You would use 97112 if it's all about movement, coordination, and balance. But if it's strength, range of motion, flexibility, then I would use 97110. Okay. Now, Medicare's policy says they believe that this code would be great for about 3 to 6 visits, maybe 12 to 18. And maybe used for 4 to 6 weeks. And if in your clinic you build 97110 on almost every patient for 12 to 16 weeks, you may have a great reason to do that. Go right ahead. I'm just letting you know that payers are going to default to Medicare and go, we expect it to be 4 to 6, and you're billing out 12 weeks of this. Explain to us why you need to do that when Medicare says that 12 to 18 is enough. And you just have to give them a good reason. If you have, you say, look, my patients are worse than the average patient because I see more auto accidents, or I see more sports injury, or whatever, or they're all 300 years old, so they need more work than the average patient, or I do certain services that require more, just be willing to explain yourself. But I'm letting you know that payers are expecting to see 12 to 18, 4 to 6 weeks. And again, if you go much beyond that, expect them to scrutinize and challenge you and have you prove to them why you should get to do more, okay? You should transition to home exercise. So they expect you to teach patients exercise, have them do it in the office, and then give them a handful of things they can do on their own so they're not dependent on the provider to get the service done, things that they can do on their own. And that's great. If you have that in your records, it helps justify your case to show that you're not trying to keep them in there just so you can run up the bill. Okay. If it's a passive exercise, then just a couple of visits is all that's generally necessary or payable. And the 97110 code does not require modifiers. The vast majority of the time it is billed by chiropractors. In the chiropractic setting, for the group of codes we use, the 5.9 modifier does not apply to 97110. And I've seen it used far too often. The 5.9 modifier is way overused. You do not need it for 97110. And if a payer tells you you do, then they have made up their own rules and they're not following CPT guidance. Okay. And some payers do that sometimes, and that's kind of problematic, but that's what it is. I'm telling you that the CPT rules say 97110 does not need a modifier on it with pretty much anything chiropractors bill, except for the one example I put here, which is if you bill it along with 97150. 97150 is the group therapy code. And the reason you would add the 5.9 to 97110 is because you had a group in there, you did some therapy with them, and you bill that. And then that patient, you took them out and did one-on-one with them for 15 minutes. And that's how you would bill 97110-59 and the group therapy code, because you did the one-on-one, which is required for 97110, and then you did the group thing for the group code, and you separately, and you're just trying to tell them with the 5.9 modifier that the one you did one-on-one is not part of the group thing. So that's what that means. Okay, so the question is, if I audited your records and I saw that you did 97110, what would I be looking for as proof that the patient needed that service? So clinically speaking, what justifies 97110? Well, as I said, It's loss of motion, strength, flexibility, some sort of loss of function, some mobility, right? If you want to say it's due to a pain issue, then try to objectify it as much as you can by including a pain rating, the location of the pain, and ideally how that pain affects function. If it's saying neck pain, great, but then go in and say, but that neck pain keeps them from sleeping, or it makes it hard for them to sit when they sit at a desk for half an hour. Just try to find a link to function, okay? And just one more time, is not covered if you're giving exercises to make them more fit, if you're just trying to make them be able to reach their toes better, more flexibility, if you want them to enhance their endurance, aerobic conditioning, weight reduction. Those are not therapeutic exercises. And so those are the kinds of things that are not necessarily covered. So if you got them to a point where the range of motion is good and you want to maintain it, it's not covered for maintenance of range of motion or strength unless you can prove that a skilled therapist is necessary to help them and be there one-on-one with them. Okay, so those are the things I would love to see in your records. Some sort of diagnosis that can be tied to this is great. Which brings us to the next code. Okay, the next code is 97112 I want to talk about. 97112 is Neuromuscular Re-Education. And this code is different from 97110 because it relates to balance, coordination, kinesthetic sense, posture, and proprioception for things like sitting or standing. Okay, so it's a little bit, well, it's not a little bit, it's a lot more specific, right? So instead of saying my patient has limited flexibility, I say, hey, my patient can't stand up. When they sit, they flop over because of damage to their muscles or their nerves. And so the purpose of my service is to teach them how to sit or stand appropriately again. Right? That's what this service is for. But if I just say, hey, their low back is tight and I'm stretching it, that's 97110. Okay, but if I say their low back is so tight that they can't, sit up, or they have to lean forward at 45 degrees, or I guess if it's tight, they could be extended, I guess, whatever. That's the difference between these codes, okay? Notice that the RVU is higher for this one, just a little bit, which means there's a higher dollar value for 97112, which unfortunately, not you guys, of course, but for some has caused them to say, well, if I have a choice, I'll build 97112 because it pays a few dollars more. And that is the wrong kind of decision-making. You should only build 97112 if you're doing it for these purposes I have outlined on this slide, and instead of the ones for 97110, which is the second bullet there, right? If it's for strength, range of motion, flexibility, use 97110. If it's for balance, proprioception, etc., use 97112. And again, Medicare's guidance on this code says they think it's great for 12 to 18 visits within 4 to 6 weeks. If you build 97112 on every encounter for 8 weeks, 12 weeks, whatever, you are definitely making yourself an audit target. I'm not saying you can't do that. Go ahead and do it, but just prove medical necessity and meet all the criteria I've outlined here, and you're fine. It's hard to do, though. It's hard to justify it for that length of time and to show progress all that time. Payers are going to jump in there and try to prove it was not providing progress, therefore it wasn't necessary. 97112 requires the 5.9 modifier also if you're billing the 97150, which is that group code. But interestingly, it also requires the 5.9 if you build it on the same claim as a CMT code, which is 98940, 98941, and 98942. So we build those CMT codes for whatever reason. NCCI edits, the edits that help us determine when the 5.9 modifier is necessary, says that you need to add the 5.9 to 97112 because somehow it's part of the chiropractic manipulation. Frankly, I don't get it. I don't understand how it could be. I think the service is so different that I can't see how it could possibly be bundled in. But if you don't want it to be denied, you need to add the 5.9 modifier to the 97112 if you build on the same claim as a CMT code, like 98940. All right. The further guidance, I think I have it on the next slide. Let me double check before I tell you. Well, I think maybe it's the one after this. You do not have to have it in a separate area from the adjustment. That simply isn't true according to CPT guidance, unless a payer has their own rule, and sometimes they do. Sometimes payers say that they make up their own rules and they don't follow the CPT rules. This is actually a quote from Aetna, which is a big insurance company if you don't work with them. And this is when they say it's okay to bill 97112, okay? They say, if you look at just the red text, I've highlighted in red here, this is great for patients who have muscle paralysis, patients who need help developing conscious control of individual muscles or awareness of the position of their extremities, patients who had severe damage to the neuromuscular system. An example would be severe trauma to the nervous system, such as a cerebral vascular accident, and systemic neurologic disease. So in other words, this is great for patients who've had a stroke and they've lost the ability to move their upper shoulder and neck or something. And your work with them is reteaching those muscles and nerves to work properly so that those can work again. That's a great example of a patient who would clearly need this service, okay? And you may have heard before that 97112 is only for stroke patients. That is not true. It is not only for stroke patients. Stroke patients is a great example of when it is necessary. If you can prove your patient had some sort of great damage or impairment to the neuromuscular system and they are unable to sit or stand or balance, or they can't use their fine motors, then you can justify the service. They may not have had a stroke, but one of those other things, that's fine. So having said that, you can see clearly that 97110 is much more common in a chiropractic office. A lot of people come in with loss of flexibility, loss of strength. Not nearly as many are unable to sit or stand, right? Some are. Some can't stand. Some have total balance problems, and you can figure out a way to help them improve that. Then you build 97112, okay? And it pays a few dollars more. So, you should if that's how they present. So what other things do I think you should have in your records to justify billing for 97112? If I'm auditing your records and I'm looking through and I want to see justification for 97112, here's what I'd love to see. Loss of deep tendon reflexes, which shows nerve damage. Loss of the ability to sense vibration, paresthesia, burning or diffuse pain in the feet, in the lower legs, diffuse pain in the fingers, nerve palsy, like foot drop. And I haven't been in full-time practice for many years, but even when I was, I only saw 1 or 2 patients with true foot drop, So, it happens, but it's not all your patients. You need to show they have some sort of nerve injury or disease that's leading to muscle weakness or flaccidity. And I've seen that a little more commonly. You get patients with stenosis and they get one leg starts to lose its muscle mass, So those are examples of cases where it might be appropriate to bill this service. Someone who can't sit or stand without assistance, someone who's lost the fine motor coordination and you have some way in your office to help them gain that back, the ability to grip or turn or whatever, and severe hypo or hypertonicity. And so those are all great examples. Now, someone is probably sitting there thinking, wait, in the description it says posture. So if I do posture exercises, can I bill this? And the answer is yes, if you can prove that their posture was lost due to some sort of great trauma to the nervous system. I don't think this applies to a patient who you say, hey, you've been sitting at your desk too long, and now you have this whole, forward head posture in your shoulders, and you've got to work on this because you've been working at a desk for 40 years, and we'll give you some exercises and stretches for that. I don't think that this is appropriate for that. You could try, I guess. They have the word posture. Now I'm thinking it's more like they lost the ability to hold their shoulders up or hold their head straight because of nerve damage to the muscles, that type of thing, not just chronic bad posture. So that's just my opinion. If you disagree with me, go right ahead and bill it and do your best. I think that you'll have a hard time winning that argument that just chronically bad posture from sitting at a desk is a good reason for this. All right. So let's talk about the last code in this group that I want to discuss that I think overlaps so much with these other two. We want to make sure we're distinctive and we're clear on what they are. 97530. This one isn't billed as commonly by chiros, and I think it could be billed a little bit more often. I think that many of us don't really know how it differs from the others. It has an even higher RVU. And by the way, this RVU is 1.1, so it's higher than the other two by a little bit. That translates to another $5 or $10 maybe for the value of this service. So it's worth more because it's more intense. There's more involved in this. And the patients who need this service have more serious problems, okay? This one, instead of therapeutic exercises like 97110, is therapeutic activities. So instead of saying, hey, the patient's just lost their strength, their range of motion, their flexibility, we're going to say, hey, they've lost several of these things. And because of that, they can't perform an activity, a specific activity. And I'm going to identify that activity and teach them how to do it again and restore their ability to do that activity because they can't do it due to somewhat, loss of function. Okay. And so a couple of buzzwords with this code is dynamic activities and functional performance. So these would include things like balance, strength, range of motion. But an example of what I'd like to see in the notes is you'd say something like the patient is unable to perform bending, lifting, carrying, reaching, catching, etc. Things that end with ing are generally good ones. You say they can't do this thing that ends with ing, like reaching, and I'm going to work with them one-on-one for 15 minutes to teach them how to reach again. And that justifies this service. Again, 15 minutes is 8 to 22. Okay, so you can bill it once if you do it for 8 to 22 minutes. based upon the 8-minute rule from Medicare, which is what most payers follow. So 97530, great code. If you have a patient who has a loss of some functional activity. Here's one way you might look at it. You might have a patient who comes in and you go, wow, this patient, they're unable to bend and lift. So we're going to start with some therapeutic exercises, right? Well, here's a sequence. We're going to start with e-stim and ultrasound to get those muscles to relax and get them loosened up and get rid of their pain. And once we got that down, maybe we only do that for 2 or 4 weeks. Then we start the patient on exercises to improve their flexibility, range of motion. So we do 97110 for another 2 to 4 weeks. We do 97110, which is strength, range of motion, right? We do that. And then we say, all right, we've got the pain down in the first phase of care. We did the second phase of care where we worked on their range of motion or strength. And now we're in the third phase of care. We're going to now build 97530 during this phase of care because now that we've got those in place, we can focus on specific bending and lifting activities, right? So it shows progression when you change those codes out. First you build e-stim, then you build therapeutic exercise, then you build therapeutic activities. That's one way as a coder and an auditor, I'd like to see the flow of the services in your office. And you can establish great, clear goals that outline what this service is trying to accomplish and how you're going to measure that. And at the end of care, you say, look, we got there. And everybody's happy. The payer will pay because they see that it was clear. The patient's happy because they're getting great results. The provider's happy because they're getting paid and they're delivering great service to help their patients. What else do you need to know about this code? Well, it does require the professional skills of a clinician, and you have to identify a functional need, a functional loss, so the second bullet here is what I just explained. This might be appropriate after the patient has already completed exercises that focus on strength, range of motion, but they have to be progressed to something that's more like a function-based activity, not just an exercise, but an activity. And these dynamic activities have to be part of an active plan and directed at a specific outcome. So you have to figure out a way to measure it. So, for example, if I said, well, this patient is unable to bend and lift up a box, and the goal over the next couple of weeks to get them to be able to bend and lift a 10-pound box, and by the end of care, a 20-pound box. And you test that, and if they can do that without pain, then you've reached your goal, and you mention it, and you specifically say, hey, we did this service, we did these exercises, the activities, over and over, at each encounter, and we were trying to accomplish this, and we did. So that's what you're shooting for with that. So just to kind of emphasize the differerences here, 97110 focuses on a single parameter, an exercise. 97530 focuses on multiple parameters through an activity. 97530 requires the skills of a therapist, just like the other codes do, typically up to 12 visits. And if you got more, this is actually from the Medicare guidance on these codes. It says if you need more than 12 visits, you need to document clearly why, because Medicare doesn't think the Newell case would require more than 12 encounters of this. All right. This code requires the 5-9 modifier. It's billed along with 97140. 97140 is manual therapy. That's the one the chiro is used for trigger point or myofascial release. And again, I'm not clear why those two codes are bundled together. But I'm telling you, the rules say that if you perform manual therapy on a patient and you do therapeutic activities, so 97140 and 97530, you need the 5-9 modifier to explain to the payer that the 97530 is not part of that manual therapy. It's its own service. And you need to document clearly, hey, we did the manual therapy and here's how we did it. We did some, trigger point work with whatever for 8 to maybe 15 minutes. And then we stopped that and we started this other thing, which was this activity. And we did that. If you're doing them all together, then it's harder to be clear on why they're separate billable services. So it's very important for you to try to clearly and distinctly show each service, start and end times, definitely. In fact, you should know that a lot of payers now, not a lot, but we're starting to see more and more, they're requiring you to say, hey, this service began at 1:04 p.m. and ended at 1:18 p.m. Instead of just saying the total time, we're seeing a lot of payers require you to put in the start and stop times. So just be aware of that. And that way you could clearly show these services are distinct from each other. In fact, I was working with a client recently who basically the payer was saying, well, you didn't say the start and stop times and you build 2-time services. So for all we know, you did them at the same time. And you say, look, it's impossible to do them at the same time. But you know what? It would have been better if the records had said we started at 1:04, ended at 1:18, and then at 1:19 we started this and stopped that at 1:28. That would be really hard for the payer to dispute. Okay. And then 97150 is that group therapy code again. So if you do therapeutic activities, 97530 with a patient, you got to do it separately, and after or before you do the group therapy, if you want to get paid for it separately, attach the 5-9. All right. 97150 is a group, 2 or more. And then the 97530 implies it's one-on-one afterwards or beforehand with this other patient one-on-one. So if you want to bill for the service, and I review your records, and I'm looking for a good cause, I'm looking for your diagnoses, I'm looking at your documentation and say, why did they say the patient needed 97530? You got to say they've lost function, and so you would say some of the same things you would say for the other codes we talked about, loss of mobility, loss of balance, loss of coordination. But then you correlate it with the patient's condition and you tie it into some sort of activity, the inability to perform an activity, all right? The patient has to be unable to do these things without the skilled intervention of therapists. So if you say, I'm going to help my patient learn to lift up a box, because they can't do it anymore, well, that's one thing. But if they can lift up the box and you just want to hang out with them while they do it, you can't build a code. It's not how it works. Okay, so make sure that you clearly explain and justify why a clinician has to be there to direct the service. Examples for that would be like if I was doing 97110 and I had a patient sitting in a chair and they were, holding onto some TheraBand that was hooked to the wall, and they were doing this, and I sat there with them and I said, hey, I want you to keep that shoulder back. Okay, you know what? You're starting to slouch. Bring that head forward. I'm going to tap on it. I want you to feel that's the muscle I want you to be, using. Can you tell what I'm focusing? That's examples of why it requires clinical skill. You're giving them pointers. You're showing them what they need to do. You're identifying the muscles for them. If you just hang out and you're talking about the last game, the last football game or whatever, that's not one-on-one contact. That's shooting the breeze with your buddy. And you're welcome to do that, but you can't charge a third party for it. Okay. So you have to prove that it's requiring the one-on-one attention of the clinician for that to be justified. So a couple more things here. I have a few more things to discuss. It's not in the slides. What we've done so far, though, is we looked at 97110, 97112, 97530. And I talked to you about some fundamentals, some basics of these codes. We looked at what each of these codes require, what the modifiers are, and when really it's the 5-9 modifier and when those apply to some of these codes, and what kind of diagnoses are appropriate for them. I didn't actually mention any specific diagnosis codes, but really it's about what you document and then finding a code that may or may not describe it. Ideally, there are codes in some cases. For example, there's a code for muscle weakness. That's a great code to justify 97110, muscle weakness, because 97110 can be used to improve strength. And so that's one example. So you can find diagnoses to describe it, great. If not, make sure it's documented clearly and you tell the story. Or the conditions that you do diagnose, like muscle strain, could clearly explain the loss of some activity for 97530. And so my purpose was to help you understand what you needed to document and minimize your denials. I want to illustrate one other point here in just a couple minutes before I field some questions. And that is this concept that I call the chain of medical necessity. All right. And the chain of medical necessity is kind of a self-audit tool. And I'm sorry I didn't throw a slide in here that describes it, but this is what I want you to do. When you look at these three codes, okay, you go look at the last time you build one of these codes and you pull it out and you audit yourself. Here's what you're looking for, just to summarize. Let's say I'm auditing a 97110, right? Very common code in chiropractic. So I look at the last time I built 97110. Here's what I want to see in the record, okay? I want to see a history of onset. I want you to be able to identify something that showed that they began a condition that relates to why they needed 97110. And a great example is a car accident, right? I want to see that, they were in a car accident, great. Or they've been sleeping on a crappy mattress for 10 years or whatever if you can come up with an onset, that's terrific, okay? If you don't have one because it's just insidious, well, you don't have one. But if you have one, that's terrific because it helps establish medical necessity. The second thing is I want you to have a patient complaint that relates to that service. So if you're doing 97110 and it happens to be on the neck and the patient doesn't complain of their neck, they say, my neck is great, wonderful. And you go, well, we're going to bill your insurance to work on your neck for 8 weeks. That doesn't correlate. You have to show they have a neck problem. So I want to see an onset. I want to see a subjective complaint in the area where you're treating. I also want exam findings. I want objective findings. You palpate the muscles. There's tenderness. There's range of motion limitation, whatever. I'd love to see objective outcome assessment tool scores that to show, loss of function. So I want an onset, a patient complaint, exam findings, and I want that to correlate with a diagnosis that supports that service. Some sort of diagnosis that can be tied to it that explains why it was necessary. Then I want that outlined in a treatment plan. I want a plan that says, look, here's what we found, this problem with this neck, here's what the issues are, here's the evidence to support what's wrong, here's the diagnosis. So we're going to do X, Y, and Z for this much time, for this purpose, with these goals. and we're going to measure it at this point in time, and then again at this point. And if all's going well, we'll release the patient, and they'll be happy, and I'll be happy, and we'll all be happy. So I want an onset. I want a subjective complaint. I want exam findings. I want a diagnosis. I want a treatment plan. And the final thing I want to see, the sixth link in this chain of medical necessity, is progress. I want you to be able to explain to me how that service shows progress. Oh, the range of motion is better. As I measure the strength, it's better. As I palpate, they complain less about tenderness. As I administer an outcome assessment questionnaire, the score has gone down since I last did it. That's progress. So the real key is to show functional loss and functional progress. And if you do that, these codes are very easy to defend, or easier, I should say. Those are the secrets to building these therapeutic procedure codes that are sometimes confused by chiropractors, and they shouldn't be. You know what? I am not going to go through these last few slides. I pasted them in at the last second. Let me just double check them though. Yeah. What I pasted in here in the last 3 slides, I don't know, Christy, can they download these slides? Did you provide them to them? Because I'm about to turn the time back over to you if you're still awake. Yeah.
I did.
The last 3 slides are the statement of medical necessity from Anthem Blue Cross. Just kind of FYI. The first 2 is, the first one is what makes it medically necessary, and the last couple are what makes it not medically necessary. Read those, and you'll see it's kind of the same stuff I explained to you, but in their own words, and just take a look at what the payers are looking for these kinds of services, okay? Having said that, I'm going to pause here and let Christy jump in. I assume there's questions. There's people that are complaining, crying, screaming, tears of joy. I don't know. So let's get in and field some of those. And we got a few minutes left, so I'm ready.
Okay, our first question. Do we need to also show short-term goals, long-term goals, and permanent goals? I mean, differentiating between them all.
So I have my own opinion about short and long-term goals. Here's how I see it. If I put together an episode of care for 8 weeks, 12 weeks, we'll say 12 weeks, to me, that's the long-term goals. And my long-term goal might be, hey, their outcome assessment score is 60. I want to get it down below 5. That's a long-term goal. And one of the things they answered in there was, you know what, I have a really hard time walking a very long distance. I would take a short-term goal at a 4-week interval and say, I want to get them to be able to walk 50 yards instead of 20 yards. And then the next phase of care, I'd have a new short-term goal that says, hey, during these 4 weeks, I want to get them from 50 yards to 100 yards. But my long-term goal is to improve the overall score on the outcome assessment questionnaire that asked about their ability to walk. So I think you can do short-term goals around ADLs or around pain issues and so on. Long-term goals more about the overall function and outcome assessment. I'm not familiar with the concept of permanent goals and how that differs from long-term goals, but I believe that you can have short-term goals that follow phases of care, like 4-week chunks, and then long-term goals that show the whole episode, and those can be different from each other. And periodically, you can talk about each one and say, hey, you know, this little goal about getting them to be able to do this for a few minutes is going to tie into this goal later of releasing them from care at maximum therapeutic benefit. So.
Okay. Our next question, are LMTs considered valid clinicians to perform therapeutic exercises?
The answer is, it depends. It depends on your state. It depends on the payers you're working with. You'll have to check and ask. In some states, you can delegate to them because they have a license. In other states, you can delegate to anybody. And so you need to check with your state boards.
Okay. I thought the 59 modifier was not supposed to be used.
Ever? Well, so the 59 modifier was way overused. So 3 or 4 years ago, Medicare came out with some new modifiers that start with the letter X. There's 4 of them, and they're more specific. They're the same thing as a 5-9, but they're more specific. And I'm trying to think. I think that payers, there may be some that have said they don't take 5-9 anymore, and they want the X instead. And none of the codes that I showed you here, I'm trying to think of which X modifier you would use, because you don't need to designate separate structure. I can't recall off the top of my head. XS is the more common one for 97140. So the scoop is 5-9. If the payer told you they don't accept it anymore, don't use it. Use one of the X modifiers. You can look them up. Just Google X modifier. Go to ChiroCode and you'll find all a bunch about it. So there you go.
Why have I never received a notification from United that we need GP codes? Are you talking about only when it's secondary to Medicare?
I got a notice from, where did I get it from? was it through my friends at ChiroCode? I don't recall, that there was an April newsletter from United Healthcare that said as of July 1st, they're requiring the GP as of July 1st. So you know what? If you build United Healthcare since then, one of these codes, and you didn't put the GP on there and they paid you, maybe I'm mistaken. But it wasn't for secondaries. It was just from now on, we want it on there. And I thought it was kind of weird because I thought that was a Medicare modifier, but that's in. So let's see. I'm trying to think of a reference. I'm trying to remember where I got it from. You can either talk to United Healthcare, search their site, look in their policy stuff, and or maybe Google GP modifier United Healthcare and see what happens, or go to ChiroCode. It probably was in one of the newsletters there, one of the blogs. Sorry, I can't.
I was just going to say we've gotten a couple of people who've popped in. So Debbie in Florida said they did receive that notification from United Healthcare, and Kathy in Texas said they also received it, but theirs does not go into effect until September 1st.
Well, there you go.
Want to make sure we didn't get that overlooked. Okay, next question. If doing 2 time codes at the same time, like electric stim and mechanical traction, can they both be billed even though only 15 minutes elapsed in real time because they're done together?
Yeah, so e-stim and mechanical traction are not timed codes. Did they say not?
Yeah.
So you're asking, can they be done at the same time and both be billed? Technically, the rules don't prohibit that. How's that?
Is there a code for the administrative time spent on documentation?
Negative. No, and here's the secret to documentation. Get a great EHR software like PayDC, like mine, and make your records solid and fast, and then it's not really an issue. Do a good note in 30 seconds, and you shouldn't be spending hours and hours on documentation. You should not in today's age. We have too much great technology. So
I will say, if you think of any more questions, you can reach out to Evan at evan.gwilliam@paydc.com, or you can email those to me. We do have a quick poll question. So if you will, let's see. Please answer that. We did get several questions throughout the webinar about whether or not today's was going to be recorded. And this is definitely something, if you're the doctor, that you probably want to share with your staff who's helping with billing and coding. And so absolutely this is being recorded, and you can access it using the link that you used to join today's live presentation, or you can also go to our website at chirohealthusa.com/archives. And that's also accessible from the live webinar page. So make sure you can go back, access it at any time. They never expire, ever.
Send the link to your loved ones, for special occasions, that kind of thing.
Absolutely. And then, so next week we have, is that next week? Oh, that is next week. Okay. I had to think about that for a second. Is that next week? Wow, this month is flying by already. So next week, we are going to be doing Section 1557 mandatory anti-discrimination training with Dr. Mario Fusionary. So that'll be a great one for you and your team to watch together as a group. You can document it in your compliance manual that you completed your anti-discrimination training. So please, again, answer the poll question before you leave today. Super important. And again, if you have any questions for Dr. Gwilliam, evan.gwilliam@paydc.com, or you can email me, Christy, at ChiroHealthUSA.com. Bye, everybody.